Good morning, everyone. I'm Allison Jackson, the Chief of the Child and Adolescent Protection Center, and it gives me great pleasure to be here this morning for a grand round to introduce the morning speaker. As some of you may know, October is Domestic Violence Awareness Month, and in our efforts to recognize those known and unknown impacted by DV and intimate partner violence, we use this morning's grand rounds to raise awareness within the children's national community. This would not be possible without the support of the Child Health Board and the Washington Children's Foundation, to which we are extremely grateful. I also want to acknowledge any guests from the victim service community today. If anyone is here, I know I extended some invitations to your hands. And also a special introduction to those who just laid their hands, who are going to lay their hand again from the DC Volunteer Lawyers Project. We're excited because later this month, they will be available here at the main campus as a resource to families impacted by domestic violence. So now, on behalf of Dr. Lenore Jarvis, who is regrettably unable to attend, and the Help for Victim of Violence Committee members. All right, let's acknowledge people for their efforts, right? It gives me great pleasure to introduce to you the morning speaker. Dr. Kimberly Randall is a pediatric emergency medicine physician at Children's Mercy, Kansas City, and Associate Professor of Pediatrics at the University of Missouri, Kansas City School of Medicine. Her research and advocacy focus includes intimate partner violence, adolescent relationship abuse, and reproductive coercion. At Children's Mercy, she serves as the co-chair of the Children's Mercy IPV Work Group and chair of the Department of Pediatrics Gender Equity Committee. Nationally, she is an abstract chair for the AAP's Council on Injury, Violence, and Poison Prevention. Please join me in a warm welcome for Dr. Randall as she presents Just Below the Surface, Intimate Partner Violence, Power and Control in the Pediatric Healthcare Setting.
Good morning, and thank you everybody for coming. 8 o'clock feels awfully early, especially when you're used to Central Standard Time. So my goals today are that if you don't already, by the end of this talk, you will identify intimate partner violence, or IPV, as a pediatric health issue, that you'll recognize ways in which IPV power and control tactics play out right here in a pediatric healthcare setting, and that you'll be able to appropriately respond when those power and control tactics are either suspected or identified. I'm going to use an audience polling system. If you want to join in, you can pull out your cell phone and text CMKC to 22333. And that it'll take a minute or so, but then you'll get a little reply back that lets you know that you're in the system and you'll be able to participate. And then a couple other housekeeping things. One is that trauma, including IPV, whether that's experience as an adolescent or an adult, or exposure to IPV as a child, is really common. And we as healthcare providers are not immune. So a couple ground rules is to take care of yourself, and that may mean not coming to talks such as this, may mean stepping out if you need to, and then respecting the experiences of others. So sometimes within the context of a talk such as this, people will share their own experiences, and part of respecting that sharing and disclosure is that we don't talk about those things outside of this setting. And then the final thing is that traditionally we use gendered pronouns referring to survivors of IPV with female gendered pronouns and abusers with male gendered pronouns. And although women are at higher risk for more serious forms of IPV, particularly physical and sexual abuse, we know that individuals of any gender or any sexual orientation can experience IPV victimization or can perpetrate IPV. So when we talk about addressing this and providing resources, we need to be able to provide resources across a broad spectrum of individuals. So IPV is really common, both worldwide and here in the U.S. And what that translates to when we think about us as pediatricians and pediatric healthcare providers or others who work in partnership with pediatric healthcare communities, that roughly 15 million kids in the U.S. every year are living in homes in which they're exposed to IPV. half of these kids are living in homes in which that abuse would be considered severe. And these are kids who, because of that exposure, are at increased risk for a whole host of negative outcomes. I think one of the key things to notice about this list is that it's not simply mental health problems. These are kids who are at higher risk for child abuse. They're at higher risk for dying from physical child abuse. And then when it comes to their health, they're at risk for physical health problems, behavioral problems, developmental delays, so not just mental illness. And these risks extend across the lifespan to include things such as decreased occupational achievement and decreased net worth when they become adults. And not surprisingly, it makes sense intuitively to think about it, but we have also studied it, so we know, we can say it's a fact that childhood IPV exposure is associated with increased healthcare utilization and costs. And one of the key things is that these costs, this increase, persists well beyond when that exposure to IPV ceases. So clearly, this is a really common problem, has significant lifelong impacts, both to the individual child and family, and then also to society as a whole. And the way that that happens is kind of what's now known as the pathophysiology of toxic stress. So our stress response, ideally, is designed to be adaptive. So it puts our mind and our body in the best and optimal conditions to survive a stressful experience. The problem comes when that stress is toxic. So such as childhood IPV exposure, when that stress is severe, when it's chronic, and when it's not adequately buffered. And then what happens is you get chronic activation of your stress response system, chronic elevation of stress response hormones, and that results in changes, including changes in epigenetics and brain architecture that can persist throughout the life of that child. It's not all doom and gloom. So we in pediatric healthcare settings have some really unique opportunities. One thing that we know about IPV is that intervention by others is often a key factor in decisions to seek help. And at the same time, we know that it's acceptable to families for pediatric healthcare providers to be asking about this stuff. We also know that parents will bring their kids to receive health services when they're not seeing their own provider. So for example, Martin and colleagues found that when they looked at women who were experiencing IPV after the birth of a child, those women were at increased risk to miss their 6-week postpartum visit with their obstetrician. But they were still bringing their children in for that immediate newborn check. They were bringing their kids for the 2-month check, the 4-month check, 6-month all-child check. So we as pediatric healthcare providers may have contact with parents or other caregivers who are experiencing IPV when they're not seeing their own adult provider. Or maybe they're seeing an adult provider who doesn't ask. I will tell you I've had 2 kids, and I was never asked in my obstetrician's office if I was experiencing intimate partner violence. So even if they are seeing their own adult provider, you don't know that they're in a place where that's being addressed. And then finally, when we talk to moms about what motivated them to seek help, the impact of IPV on their kids plays a really large role in that decision. And who better to talk about that impact than pediatric healthcare providers? So one of the things that I think we have to be aware of that we haven't thought about as often, there's not really any literature about it out there that I'm aware of, is the fact that power and control tactics sometimes play out in pediatric healthcare settings. And they can be hard to recognize, but if we want to provide robust services and a robust response to IPV in this setting, we have to be aware of these. That's what I'm going to focus the main focus on. Before I get into power and control as it manifests in pediatric healthcare settings, so I want to make sure we're all on the same page and talk about what is IPV. So this is your first opportunity to play along with a poll. You can take out your phone. It works best if you just text a one-word answer. If you text 2 words, it tries to split them up in the word cloud. Do you want to just call out an answer? I know we tested it before. It did work? Okay. Is it working? All right. If you want to just yell out a word instead of bothering with your phone, that's also cool, and I can repeat it to make sure everybody hears. Maybe you want to yell out words anyway. Okay, so it's the isolation, intimidation, depression, silence. Anything else? We'll give it a couple more minutes. Control. Alone, obfuscation. Ooh, fancy word. All right. Blame. So verbal abuse. Power is in there as well. So yeah, all of these things I think are good descriptors. So this is the wheel of power and control. How many have seen the wheel? In the DV world, we use wheels a lot to talk about how some of these behaviors manifest. So what the wheel here, this is the components of the wheel were taken from the voices of survivors as they shared about their experiences. I think there's two key things here to recognize. One is that there are a lot of ways to abuse somebody, and physical and sexual abuse is only a part of it. In fact, you can be in an abusive relationship and never experience physical or sexual abuse. Some of the other ways that abusers, some of the other tactics they use, they may use coercion and threats, intimidation, emotional abuse, isolation. So some of these words that we just saw, you guys submit for the word cloud. Minimizing, denying, or blaming, which is called gaslighting now. They may use children, the ideas of male privilege, and economic abuse. But what underlies all of these tactics is maintaining power and control over the other partner in the relationship. And one of the things that is not on this wheel, but at Children's Mercy we have slowly become more aware of, is that a children's healthcare setting is a really nice place, provides a lot of opportunities to exert power and control in a relationship. And so I'm going to talk a little bit more about that in detail, and I'm going to use some cases that I've experienced or that have been shared with me or that my colleagues have experienced. So this is case one, a mom who was at the hospital with an admitted child. When father came up to the hospital, she got in his car to talk. He proceeded to drive away against her will and physically assaulted her in the car. Later on, back in the inpatient unit, both parents were there, and he continued to verbally and physically assault her. These instances were unwitnessed by hospital staff, but the mother notified the inpatient team about what was occurring. They talked to the father, who denied that anything had happened. Well, I don't know what she's talking about. This is just what she does. It's just, part of her thing. And kind of as that conversation continued, the mom got increasingly upset, and the dad just kind of remained calm, cool, and collected. We had it together throughout the whole conversation. So thinking about this scenario, what should happen next? So there are a couple options. Staff can inform the mom that nothing can be done, and you can text in either A, B, C, or D, and it'll register your answer up there. The staff can inform mom nothing can be done. It's a he said, she said kind of thing. You can consult social work, so it's time to phone a friend. Making a safety plan, offering IPV resources. You can only pick one. It's kind of a trick question, right? So I'm so happy to see that nobody is choosing A, because B, C, and D are all good things, right? We would want all of these things to happen. We want to pull in somebody. If you're the physician or the nurse, to pull in somebody with a little bit more expertise, so you're phoning your social work colleague who's going to work with the team to make a safety plan that addresses safety of both the patient, the parents, and then the hospital staff, and then to offer IPV resources. What happened in this case is that hospital staff told the mother that it was he said, she said, and nothing could be done. Yes, I hear some gas. So the mom continued to request that the issue be addressed and said, hey, why don't you see if you can review some security footage, which did indeed confirm that physical assault had occurred. The decision at that time was made to restrict the father's visitation and appropriate resources were provided. But I think what this case illustrates is that sometimes what is the clear right course of action when you're sitting in a context such as this is harder to implement maybe in real life when you're in the heat of the moment, and who knows how many other patients the team had to take care of, what else is going on the floor. And so to kind of talk a little bit more about this, this is a wheel that myself and colleagues at Children's Mercy and then Rose Brooks Center, which is our primary community IPV agency partner, have put together. The caveat is based on our own experiences. I am submitting, hopefully by Friday, an IRB protocol to look at this with a qualitative study so we can look at it in a more systematic fashion, but this is what we've seen. So is that power and control tactics play out in a lot of different ways in the PAEDS healthcare setting, and they're not always easily visible. So it may be accessing the child's medical records, and by doing that, the abuser learns of an IPV disclosure of the specific resources that have been used. It can be withholding, so withholding things like medicine or equipment at transitions of care between two households when a couple is co-parenting, or not sharing information about treatment plans and appointment times. It can be discrediting the non-offending parent, so maybe sharing concerns about the non-offending parent, blaming the non-offending parent for incidents that have occurred on site, or when an incident has occurred, such as the case that I just shared, and the non-offending parent is visibly upset and kind of really worked up, understandably, and the abuser remains calm, cool, and collected. Could be bringing a child in for abuse and neglect evaluations when they're in the care of the non-offending parent. And then there's also limiting the child's access to medical care as a means to maintain power and control over the non-offending parent. So this may mean not providing transportation, withholding payments, withholding insurance cards. They may limit the non-offending parent's involvement in medical care, so making appointments when that parent isn't available, or for families who don't speak English, limiting access to interpreters is a big way to limit involvement in the child's medical care. You can use the information available in the medical records really easily to stalk your partner. So appointment dates and times, you know exactly where to show up, exactly where they're going to be. And then the medical setting provides just a lot of opportunities for general harassment and intimidation of your partner. And then perhaps even as in this previous case with overt abuse, overt physical or verbal abuse that is witnessed or not witnessed by staff. So case 2, these are parents who were present at a child's admission from the emergency department. The patient needed to go to the OR the next day, so was admitted. And when the inpatient team came in to assess the patient at the admission after arrival to the floor, it was only the dad who was present. He said mom had gone home to sleep, and she would be back in the morning before surgery. Well, the next morning she wasn't back. It was time to go to the OR. They couldn't delay things anymore. Father told the staff, I've got no idea where she is. I mean, she said she's going to be back, but I don't know. So when the mom did arrive after surgery, she shared with the staff that she had gone home at the dad's suggestion. He said, one of us at least might as well get a good night's sleep. Let's let it be you. I'll call you and give you the OR time as soon as I know it. That way you can come up and, do kisses and hugs goodbye before our child goes back to the operating room. Well, he did not call her with the surgery time. He did, however, call her an awful lot, tell her what a horrible mother she was for leaving her ill patient who was so ill they needed surgery in the hospital that night. So what forms of abuse, what tactics do you see in this case? You can just yell them out. So harassment. Yeah, so he's withholding information and limiting her involvement in care. Verbal abuse. Demeaning and manipulative. He's also, if you think about so in this particular case, the tone he used when he told staff in the morning, I don't know why she's back, she said she would be, that was discrediting her with hospital staff. I'm the good parent. I'm the one who stayed all night. I'm the one who's here before OR time to give hugs and say we'll see you later. If you're an abuser, the nice thing is that, 1 or 2 actions can be a whole range of power and control tactics. I'm going to talk a little bit more about this, but we have another polling slide. So this is just a true-false. You can enter A for true and B for false. Power and control tactics do not continue after a couple separates. Yeah, absolutely. But again, I think this is one of those things that when we're sitting here thinking about it, it's really obvious. But in the real world, sometimes it's not so obvious, and this manifests in our thought and our idea that I know, I do this work a lot, and sometimes I still catch myself thinking this, well, why don't they just, that's going to fix everything. Just get out. But what we know is that power and control tactics often continue even after a couple has separated. And when you have children together and you have to co-parent, that gives an awful lot of opportunities to continue to perpetuate abuse. So this is the post-separation power and control wheel. So it includes things such as using physical and sexual violence against the children. So one of the barriers for some parents in actually leaving the relationship is getting out is the knowledge that perhaps the children are going to have unsupervised visits with that abusive parent. There's also using harassment intimidation, so destroying things belonging or related to the kids, potentially undermining that non-offending parent's ability to be a parent. So maybe disrupting kids' sleep schedules, not following through on schoolwork, not maintaining good limits over behavior and rules, so undermining what the work that the other parent is doing, discrediting the non-offending parent as either a mother or a father, withholding financial support, endangering the children or disregarding the children, and then disrupting the non-offending parent's relationships with their children. So that may mean coercing them to ally with the abuser. It may mean using the children to kind of keep tabs and stock what that non-offending parent is doing when they're away from the abuser. So when we speak about the idea of leaving, well, that can certainly be an important step towards safety, and ideally the goal is that people would no longer be in abusive relationships. We have to think about just because somebody separates from their abusive partner, particularly when they have children together, it doesn't mean that power and control tactics end. And so in this case, we have parents who have been separated or divorced for 8 years. The mother brings the patient in for scheduled follow-up visits, and staff have noted that multiple previous visits have been missed. So how do you know why this family is missing appointments? You can either make a quick assumption, choice A, ask in a judgmental manner, choice B, or ask in a trauma-informed manner. Right, so obviously you're all picking C. But again, I think this is one of those things that in the moment, sometimes the right thing to do is not always the easy thing to do, right? At 3 a.m. on a busy night in January when flu and RSV season is in full swing and the ER is kind of a madhouse, it's a lot harder for me to go for choice B, right? So we have to kind of check ourselves and be careful about our own responses. In this case, the clinic staff did ask in that trauma-informed manner in a way that the parent felt comfortable disclosing that, yeah, we are missing a lot of appointments, and it's generally the child's father who's scheduling the appointments. He always schedules them for a week when she's with me, when I'm the primary parent. He's not forthcoming about providing appointment information, so often he won't let me know that those appointments are scheduled until the morning of. And then despite being the one to schedule the appointment, he refuses to ever help with getting the child to the appointments because it's not his week. He's not the parent this week. She's your responsibility. And that forces a mom to request time off from work to bring the child to clinic. And as we all know, a lot of places of work are not very flexible. They don't offer a lot of time. If you're working only for an hourly wage, missing work for a clinic appointment may mean that you're missing those hours worth of salary. So it can create some really significant hardships. So in this case, again, we see that power and control is exerted in multiple ways, right? So he's withholding information. He's inhibiting her ability to provide the medical care that the child needs. He's discrediting her because the child is missing all these appointments when she's in mom's care. And then there's financial abuse as well by the issues related to missing work. So these things that we've talked about, a key theme that I noticed as I was putting this together is that often we would not have known about this unless somebody asked. So these are not things that are just out there on the surface and that are really obvious. So when it comes to identifying IPV power and control, we have to keep IPV on our radar. If we're not thinking about it, we're not going to be asking about it. We may miss subtle cues this is going on. So as a part of trauma-informed care as a whole, we want to keep IPV in mind when we see child behaviors or symptoms that could be a result of trauma. when parent behaviors are concerning, when compliance with treatment plans are not optimal, when outcomes aren't ideal or expected, or obviously when restrictions for visitation or contact with other individuals are requested. Now, clearly, this is not a list that is specific just for IPV, right? There are a lot of things that can result in non-optimal treatment compliance, suboptimal outcomes. So we can't make the assumption that just because we see this stuff that IPV is what is going on. But we need to kind of keep that broad mindset about what has happened to this parent, what has happened or is happening with this family that is resulting in these outcomes that aren't what we're looking for. And so a lot of times the only way we really know is to ask about it. So this can be done by you or me, so meaning us as physicians, nurses. Could also be done by our social workers. We are lucky to work in a setting where we have social work services that we can consult. But asking accomplishes a couple things, no matter who does the asking. One is it tells the parent, you can talk to us about this stuff. This is something that we can have a conversation about. You don't have to just keep it private. And then because you let them know that, it provides opportunities for us to talk about underlying issues, so IPV and other issues that are often not discussed, but things that clearly impact children's health, that impact families' ability to comply with treatment plans, that impact our ability to develop the best plans for families that take into context kind of the full setting, not just a little tiny sliver of a family's and child's life that we're seeing right in front of us. And then if there's a disclosure made, clearly we have opportunities to better ensure safety. And then we can connect families to resources that are tailored individually for their situation and circumstances. And ultimately, our goal is that by asking and learning about these things, we are improving child health, not just in the now, but across the entire lifetime of that child. Case 4, we have a social worker who was called in to assist with patient behavioral issues that were impacting treatment compliance. So basically, the kid is resisting what she needs to do. The parents are separated but have attended this clinic appointment together. And when the social worker goes in, she initially attempts to meet with each parent individually to discuss behavioral concerns before meeting together. And the father suggested that because they're co-parenting, it would actually be better for them to all meet together. And he stated several times that he just really wanted to be on the same page as the patient's mother. They could have a consistent set of expectations at both households. So if you were the social worker, what would you do at this point? Do you just acquiesce to the father's request, because it is true that co-parenting goes better when everybody's on the same page and the child has a consistent set of expectations? Do you speak to the parents together now, but then do some individual follow-up later? Or do you tell them that it's routine practice that we speak to both individually? Yeah, so we're seeing a smattering of responses, most for telling the family that it's routine practice to give family or the parents both individual and joint time together. And then kind of evenly split minorities for A and B. And I think ideally, B or C would be the game plan, kind of depending on your own individual routine practice and the practices and procedures for the healthcare setting, the clinic, or the ED or inpatient setting where you're working, but that you would give each parent a time, an opportunity to speak to you individually. And in this case, the social worker followed up with the mom by phone call the next day. And at that phone call, the mom disclosed that despite their separation, the parent's separation, IPV was ongoing. And she was concerned that that exposure to IPV was actually impacting some of the patient's behaviors. So at that point in time, the social worker was able to provide IPV-related resources, including resources specifically about co-parenting within the context of an abusive relationship. So a couple things about asking that will make it go a little bit better as far as our relationship with the patients and families we're serving, and then the optimizing our that families will feel comfortable disclosing. So one is to keep it confidential, and this is the primary reason for this is to optimize safety, because potentially it increases risk if an abuser knows that somebody is trying to leave a relationship. And then also it may promote disclosure even if they're not with the abuser, if they're with another individual who doesn't know that the abuse is occurring, or perhaps it's an individual who is colluding with the abuser, they're not going to feel comfortable disclosing in front of others. And the other thing is that it prevents reinforcing to the child that IPV should be kept a secret. So if a verbal child or a child who can understand language is present and the parent says, no, this is not happening, then potentially what we've done is provided an opportunity to reinforce behavior that is less desirable, that the child says, you know, this is something we keep a secret, we don't talk to other people about, and we don't accept help for it. And so the general national consensus recommendation for asking about IPV verbally is it be done with only one adult in the room, no matter who the other adult is, even if it's like the sweetest little grandparent you've ever seen. And no verbal kids, which is generally considered ages 3 and above. And then the other thing that we want to be careful about when we're asking families about IPV is we do it in a way that minimizes perception and judgment. So the most commonly recommended way to do this is to start with a framing statement, so something that's really general, that puts your specific questions in the context of the stuff that's really common, and we know it impacts kids and families, so that's why we're asking. And then after that framing statement, you follow it up with a prompt or a question. So for example, we know there are a lot of things that can make it tough to keep appointments, and many of the families that we take care of have challenges with doing this. Please tell me about some of the things that make it tough for your family to keep appointments. And so you've done a kind of general ask that opens the door for that parent to let you know if there's something bigger going on. And then I think one of the key things to remember after we use our framing statement and we give a specific prompt or question is to take a pause. A lot of times we ask the question, and if somebody doesn't like jump right out and answer it, we're already moving on to the next thing. I think there are a couple of reasons for this. One is, in general, there's always a bazillion things to do, right? There's always the next patient, there's always notes to do, there's always script refills to call back, there's a sedation in room 3. So we're always thinking about that next thing. And also sometimes questions like this can feel a little bit awkward, even for people who have been talking about this with families for a long time and are really comfortable with it. And so kind of to combat that awkward feeling, sometimes we just ask the question and we move right on. But what happens is the question or the prompt has opened the door, and if you don't pause, you're not giving the family time to walk through it. They've got to make a quick decision. They have to weigh the pros and cons of disclosure and then decide what they're going to say and get it out. So one of the tactics that I use to help myself remember to pause is sometimes when I'm going into a room and I know I'm going to have this conversation, is I remind myself, okay, after you asked about it, count to 3 or count to 5 in your head. And part of that is because the pause always feels really long, even when it's just a couple seconds. So by counting to myself, I am a little bit more objective about how much time has really passed. So we'll move on at this point to talk about how do we address these tactics when we know that they are occurring. And this is your last polling response. Again, just a true-false question. So there is an inherent power differential between hospital or clinic staff and a child's caregiver. Is that true or false? Yeah. Right. Again, this is another one of those, well, of course, Tim, we all know that. But when it comes to taking care of patients in the moment, in real life, sometimes we don't stop and think about what this means. But we hold positions of authority, and we hold positions of considerable power both within the healthcare system and outside of it, so with other systems that our families interact with. So that's school systems, it may be the legal system, it may be the child protection system. And this inherently can create a barrier to disclosing something such as IPV. Because sometimes systems, processes, and even individuals, typically inadvertently, can perpetuate power and control toward a victim or toward a survivor parent such that it makes disclosing IPV harder and it makes it easier for the abuser to keep right on as you see. So this is your final wheel. This is the wheel of medical power and control. The caveat is that it was developed primarily thinking about adult healthcare settings, but a lot of these things apply to us in the PEDS world too. And I'll say that I don't think that in general medical providers walk into a room and like saying, I'm going to wield the medical power and control of blaming the victim. but if we're not careful, we might be doing it anyway. So these are things that we might just inadvertently do. So we might trivialize and minimize the abuse by not taking the danger seriously when a parent expresses that they have concerns maybe about the other parent visiting. We may blame the victim, and I don't think this takes any such obvious form as like, well, she's responsible for what's happened to her, she deserves it. So I think the most common way that this manifests is when we think, well, why don't they just leave? Why don't they just get out? And that's shifting that responsibility from what is happening to the non-offending parent when we should be holding the offending parent accountable for their abusive actions. Another way to perpetuate power and control in the medical setting is to not respect a non-offending parent's autonomy. And I think the easiest way to do this is to respect parents' choices about what resources they will access and utilize and when they do that. We may ignore the needs for safety, normalize victimization, or also violating confidentiality. So all of these things are things that we need to be aware of when we're working with families so that we don't contribute to power and control. And along the same lines, so this is a list of kind of attitudes or mindsets that also can perpetuate colluding with an abuser. And I think one of the more common ones is just like, well, I actually kind of like this person. I mean, they seem really nice. They're always calm, cool, and collected. They seem like they're on top of their child's medical care. And the thing about IPV is that there's no socioeconomic, racial, ethnic, religious strata that this doesn't touch, right? So there are going to be some people that just seem really nice who are actually abusers. And it's, I think, similar to what we talk about when we think about child abuse, that is, if you only go based on the impression you get of a family, then you're like, well, they just seem too nice to have done something like that, then you're going to miss things that need to be addressed. When we talk about intervention for individual families, I certainly don't want people here to feel like you have to have all of the answers. One of the nice things about working within a healthcare system is that we can have competencies that are commensurate with our roles and responsibilities. So everyone, I think, needs to have baseline competencies, knowing that if somebody makes a disclosure, you need to listen and to truly hear that disclosure and then to validate it. And that doesn't have to be anything fancy, so you can simply say, thank you for sharing that with me. I know these aren't easy things to talk about. I'd like to connect you to somebody who can give you more information about resources. And then you phone your social worker friend. If you are working in a setting where you don't have easy and ready access to social workers, there's always the National Domestic Violence hotline that families can call, and you can offer to let them call from a clinic or the inpatient or the ED phone. That way that phone record is not on their call log. And then you want to assess for safety both in the now and then also thinking about child safety when they're leaving the medical setting, provide resources, and then create a plan. And that plan might include things such as what needs to happen with visitation, on-site escorts, visitor restriction, and then how future communication, say, regarding appointment dates and times is made. And then a really common barrier is the he said, she said. So thinking back to that first case that we had, and oftentimes you have two individuals who are giving very disparate accounts of events. And when you find yourself in that setting, I think it's a signal to take a step back, to listen to both sides, and then to look below the surface and ask questions that will let you find out what is happening below the surface, what has happened in the past. And then as you're working through that, to keep bringing the focus back to the child. So what do we need to do to ensure the safety of the child? What do we need to do to ensure that the child receives the medical care that they need? And to bring the plan back to keeping the focus on the child. And then, of course, through all of it, we want to be trauma-informed and sensitive in how we're approaching caregivers in this situation. I would love to be able to give you like an easy, here's how to deal with this, because it happens commonly, and I think it gives us a lot of sometimes angst. But there is, unfortunately, no easy way. It's just going to take kind of getting in there and doing some work and talking to families and thinking it through about how to make a safety plan and get the child what they need. And one of the things to consider when you're working with abusive parents is just as the impact of IPV on kids may motivate help seeking for that non-offending parent, it may also motivate change for an abuser. So David Mandel has done a lot of work looking at how we address the co-occurrence of IPV and child abuse. And so he found, when talking to abusers, that they did understand that their violence produces negative emotions in their kids, that their actions negatively impact their relationships with kids, and they were upset by thinking that that could have long-term negative impacts on their children. And they were also upset by the idea that their child may be blaming themselves for what's going on. So that kind of gives an angle into working with an abuser, especially in the kind of finite time that we are with them in a healthcare setting, to keep, again, bring that focus back to the child and what that child sees and the impact of what's going on the child. And then ideally, we can partner with an IPV Advocacy Service, so a community agency or advocate, because they can offer a whole range of resources beyond what we as a healthcare institution can. So a lot of times people think just about shelter, but they come in and they can offer immediate emotional support, safety planning for the now and the long term, education on IPV dynamics, legal advocacy, financial empowerment, so a whole range of services, and they can tailor those services for individual families. So this is the last case. This is a mom of 3 who brought one of her kids to the hospital for a follow-up appointment. So she was in a clinic. We do universal IPV education and screening in this clinic, and her screen popped up as positive. The social worker met with her and accepted a referral, an advocate referral. I think it's important to note that she'd been screened previously and it was negative. But this time happened to be the right time. I think this speaks to the utility of universal education and screening, because we don't know when it's going to be the right time for families to make a disclosure. And this day, what the mom disclosed to the advocate was that the violence had been escalating. That morning, he had drug her out of the house by her hair and attempted to strangle her several times after the kids left for school on the bus. She'd actually left this relationship several times, but each time came back because of concerns about her kids being homeless. So that day, the advocate was able to work with the mom to develop a safety plan. Together, they filed an order of protection and found safe shelter for the mom and all 3 of the kids. And then the advocate worked with the school to get the 2 kids who were at school from school to that safe shelter. And then they started the process of getting pro bono legal services. And then that family continues to receive ongoing services from our advocacy partner. I think this is another key thing, is that the advocacy partner can follow up with families and continue to get them what they need. So for example, for this family, they've helped the mom work with the school to develop plans for safe after-school activities and some really tightly outlined plans for who can pick the kids up from school. They've also worked with mom to help her recognize some of the power and control tactics that she hadn't labeled as such, and then encourage her to talk with her lawyers about them, again, so that the perpetrator's actions, he can be held accountable for those within the legal system. And then thinking a little bit more broadly about system intervention. So one thing that we can do at a children's hospital is have an environment that promotes identification and disclosure of IPV. So we can practice broadly trauma-informed care. We can put up environmental cues. So this on your right is the poster that we have up in our ED exam rooms and restrooms in our urgent care that lets families know that we have resources. It gives them the number so they can make the decision to call without ever having to make a disclosure to us. And there's a pamphlet here that provides more detailed information. It's kind of a little multi-pocket law holder thing. And then we can also educate our staff, again, to ensure with their roles and responsibilities, so we all don't have to have the expertise of an IPV advocate, but we need to know, how does the family get to the advocate? What is our role in getting the family that offer of referral? We can do things such as universal education and screening, and then also safe documentation practices. So I'm going to touch just really briefly on trauma-informed care. We could do like a whole day workshop on this alone. I think the key thing for us to keep in mind is to shift our perspective, that when we're working with families, when we're working with patients, when we're working with our colleagues, that we approach it from a perspective of what has happened, that the end result is what I'm seeing in front of me now, rather than, I think sometimes it's easy to fall back on these, what is wrong with this family? And it's important to keep that what has happened perspective in mind, because trauma is really common. It's often not visible, but it definitely impacts responses to the current situation. And then finally, about trauma-informed care, self-care is really key. We do a job that is physically and emotionally exhausting. And when you couple that with the fact that the right thing to do is not the easy thing to do, if we're not taking care of ourselves, then if we're tired physically, if we're tired emotionally, it's really easy to fall back on some of those assumptions, such as the whole what is wrong with the family idea. And then I'm going to close with talking about risk of documentation. So while documenting is really helpful for continuity of care and sometimes can be useful in legal proceedings, it's also particularly risky when you're in a pediatric healthcare setting because the abuser is often somebody who has access to the child's medical records. So if they get a hold of that documentation, they can learn about disclosures, they can learn about help seeking and safety plans, specific resources utilized, and we can increase risk for estimated violence. Because we know the evidence shows that help seeking and leaving the relationship is a trigger for increased violence. And one of the things that we're starting to see among our population is that caregivers who accept an advocate referral may be at particularly increased risk. So our advocacy partner uses the Maryland Lethality Assessment Program assessment, which is a validated assessment to look at intimate partner homicide risk. So every family that they meet with, every client they meet with at the hospital, they administer the assessment to if the client is agreeable. And what we've seen is that 86% of the caregivers coming through our doors to accept an IPV advocate referral screen as high risk for intimate partner homicide. So in particular, those families who choose to make a disclosure when they're at our hospital or our clinic or our ED may be at higher risk, and we need to keep that in mind. So the general expert consensus is to use limited or coded documentation. So at Children's Mercy, we just say bridge positive in our social section of the note. Our IPV program is the bridge program, the advocate is bridge advocate, our intervention is bridge interventions, we just say bridge positive, and people know what that means. And then our social workers will document in more detail. Their notes have layers of protection that mine as a physician or that our nursing staff, that those notes don't have. Key things to include, no matter how many layers of protection your note has, is not to include safety plan information as part. This includes things such as saying living in a shelter, even if you don't specify that it's an IPV shelter. You also don't want to use IPV-related diagnostic codes because if the abuser holds the insurance, you may see that on an explanation of benefit mailing. If you do need more detailed documentation, you want to think about what are the means within your system to protect a note. So some people will have protected note types where medical staff can see the note, but if the record is requested, that note doesn't get released without permission. At Children's Mercy, we have a denied disclosure request, so we can request that information not be released to, in general, or to a specific person. You can flag the chart or visit as confidential at some facilities. And then the other thing to keep in mind is just the idea of practicing informed documentation. So talking to the non-offending caregiver about what you think is important to document and why, and then getting their input on safety related to that. And the key thing to remember is that all of these things protect against, but they don't guarantee that records wouldn't be released, particularly if legal proceedings are occurring. And then I'm going to close with some IPV resources. So as I mentioned at the beginning, we as pediatric healthcare workers are not immune to this problem. So it is a guarantee that we are sitting in the audience with people who have been impacted by IPV. And so I wanted to put resources up here. There's the National BV Hotline and website. There are some local numbers. And then I also put a couple really good websites for adolescent relationship abuse. And I need to for sure give a shout out to Tanya Draper-Douthit, who is the Community Program Coordinator at Rose Brooks, our IPV agency partner, and then Jennifer Selbomer-Royer, who is one of our social workers who is a staunch IPV champion. They actually helped me put this lecture together because we're giving it as a three-person presentation in a couple weeks back at Children's Mercy because I left up with me today. And I'm happy to take any questions. This is what my kids do when they spend their summer weeks with my parents.
This was just fabulous. Thank you for continuing the conversation here at Children's about this importance of trauma-informed care and screening and referral. You know, I'm interested in outcomes of this practice. Is there data that this, for example, improves outcomes for young children with, say, chronic disease of some kind? You know, when you're trying to manage a complex medical regimen in this context, do these screening and referrals ultimately actually improve the child's outcome?
So that's a really great question. There is not any evidence out there about that. So there have been no studies that have looked at long-term outcomes of IPV education, screening, or referral programs in children's healthcare settings. There's a few out there in the adult world. There's a couple that people have used to say that screening is not useful, but I think I would take issue with that because the intervention they provided was something like handing people a piece of paper with a list of resources, which is, we all know that doesn't cut it for this kind of thing. We have a paper coming out about our program at our institution, but it just has immediate outcomes. So who accepted referrals, what were some of the resources provided, and then St. Christopher's in Philadelphia has a program called CAMP as well, and they have a paper out, but again, it's more about those immediate outcomes. There are a lot of challenges to doing a big study such as this, not the least of which are safety of following up with families after they leave the hospital. So somebody wants to give me a lot of money, I would love to do that study.
It would certainly be a difficult randomized trial to do.
Right.
Another question, in the same vein, with physical abuse, it's an axiom that the relationship with the parents or the potential abusers and the reporter is pretty well gone after reporting. What is your experience, especially with the less physical aspects, but the disrespect and the manipulation? What is your experience with your ongoing care for relationship for medical care in those families with which you encountered this circumstance?
So I think oftentimes in the families that we've worked with, we don't have a lot of encounters with the abuser. For those families that maybe both parents are actively co-parenting and one of those parents is an abuser, I think the first step is being aware of what's going on and then making sure that you have processes in place so that, appointment times are known. Like one parent can't schedule an appointment, the abusive parent can't schedule an appointment and not call the non-offending parent. It becomes a little trickier when you think about the opposite, right? Because of the potential for stalking and harassment. If there's an order of protection, it makes it really easy, but oftentimes there's not. And so that involves, I think, the social work team getting in and kind of ferreting out some of these dynamics, and then setting up really clear expectations for how we expect people to be behaving when they're at the hospital. Yeah, I don't have a super great one-size-fits-all answer for that. If you have things that have worked particularly well here, I would love to hear them and take them back.